Okay, so we were talking about the respiratory system, and we stopped here. You know that your lungs are covered by connective tissue membranes, and those connective tissue membranes are called pleura. There are two layers of pleura. Outer layer is called the parietal pleura, and inner layer is called the visceral pleura, similar to your pericardium around the heart, right? Outer one is the parietal, inner one is the visceral. And in between those two layers, you have the cavity called the pleural cavity, the space in between those two. And that cavity contains a fluid called the pleural fluid. And like your heart, your lungs also expands and contracts, right? You know that. So the fluid in between those two layers reduces the friction, rubbing. If there is no fluid, then the two layers will rub each other against each other and will cause pain. Okay, and so pleuritis is the inflammation of the pleura, in which the amount of fluid can decrease and the friction between those two layers can occur. Okay, so pleuritis is the inflammation of the pleura. Mechanisms of breathing. You know that the respiration or breathing has two phases: inspiration and expiration. Inspiration is also called inhalation. You inhale the air, take the air inside the lung from outside. That is the inspiration or inhalation. And the next phase is called the expiration or exhalation, pushing the air out from the lung to the atmosphere outside of the body. Okay, so those are the two processes or phases of respiration. Now, which one is active? Which one is passive? When you take the air inside from outside, that is the active process. So inspiration is the active process because you use the respiratory muscles. Okay, you contract the respiratory muscles to do that. And you know that contraction of the muscle is an active process. You need ATP, right? So it is an active process. Then after the lung expands, you see, this is your lung. After the lung, you expands your lung by using the muscles. Then what happens? The muscles relax, and lung is highly elastic, right? Highly elastic. So it will contract by itself because you have forcefully expanded it, right? So now if you leave that pressure, then lung will recoil. So that's why it is a passive process, right? Because you are just think that you have a elastic thing. If you expand forcefully, then when you leave the pressure, it will go back, right? So you don't need to use the pressure in that case.
I thought the diaphragm.
Yeah. So go ahead.
I thought the diaphragm did it. You go back up and then.
Yeah, when you it actually when diaphragm relaxes, it will move up. So it's not a pressure. So that's why the inspiration is an active process and expiration is a passive process because the Lung tissue is highly elastic and it will recoil. Now, how about forceful expiration? Now you see, you have inspired the air, that is the active, expired the same amount of air, that's the expiration, right? Passive. Now if I ask you to do more forcefully, forceful expiration, forcefully push more air out, then that is an active process, because in that case you have to use the abdominal muscles, right, to push more. So forceful expiration is what? Active or passive? Active. Okay, but normal expiration is a passive process. When you use forceful expiration, can you tell me?
Before a test when we're trying to come down.
When you do the exercise, right? During exercise, you forcefully inspire and expire, right? You use the abdominal muscles a lot. Okay, so those are the two processes. Now, to understand the mechanisms of respiration, you need to know three pressures. You need to know how many? Three pressures. Atmospheric pressure, intrapulmonary pressure, and intrapleural pressure. Those three pressures. Atmospheric pressure is the pressure in the atmosphere, that means outside of the body. And the atmospheric pressure at sea level where we live is 760 millimeter of mercury. 760. Is it fixed or changing? Outside of the body the pressure is not changing. Okay, it is fixed. The air pressure is fixed. Okay. Outside pressure is fixed unless something you create. Okay, normally the atmospheric pressure is 760 millimeter of mercury, that is fixed. Okay, unless you create some situation where the pressure will increase, but normally it is 760 millimeter of mercury. Now, intrapulmonary. Intra means inside, pulmonary means what? Lungs. So inside the lungs, the pressure is the intrapulmonary pressure, which is also called intra-alveolar pressure. Makes sense because lung is filled with alveoli, right? Those are the air balls. So intrapulmonary, also called intra-alveolar pressure, which is not fixed. This pressure changes. So atmospheric pressure is fixed, intrapulmonary pressure is not fixed. Make sense? It changes. Now, how much the intrapulmonary pressure changes? This is your lung and this is outside of the body, okay, atmosphere. It's outside of the body, 760 millimeter of mercury, okay, fixed. Now, intrapulmonary pressure is not fixed, it changes. How much it changes? From 759 to 761. Within that narrow range, okay, 59, that means 1 millimeter less than this, and it can go up to 761, 1 millimeter higher than this. So sometimes it goes 1 millimeter lower and sometimes it goes 1 millimeter higher than this. Okay, so that's the intrapulmonary. Now, you know that there are two layers of pleura, and in between those two layers of pleura, you have the intrapleural. That means this is here, the pressure is intrapleural. This is what? Intrapulmonary, right? Intrapulmonary. It changes. Intrapleural pressure is always negative or less than the intrapulmonary pressure. So this is the intrapulmonary pressure, and this pressure inside the pleural cavity is always negative. Always less than intrapulmonary. Okay. So those are the three pressures you need to know to understand the mechanisms of breathing. Now, what is the intrapleural pressure? You see in between the two layers of the pleura, that means pleural cavity, is 756 millimeter of mercury. Okay. So those are the three pressures you need to know. Now first, why the interpleural pressure is always less than the interpulmonary pressure. Interpleural pressure is the pressure around the lungs, right? Around the lungs. And that negative pressure will keep the lung expanded. Now you think that if this pressure here is higher than interpulmonary pressure, then what will happen? The lung will collapse, right? So that's why to keep the lung always in some extent expanded, you need the negative pressure there outside of the around the lung.
Okay, so when someone has like class 1 or whatever, is that what's happening? The outside, how can the inside end up having left just because they're sometimes jarred really hard and it pushes it out? Or
If for any reason the interpleural pressure goes above the interpulmonary pressure, then the lung will collapse. You understand that, right? Okay. So one situation we know that if someone stabs you here, okay, then what will happen? The air will outside pressure is 760, right, in the atmosphere. So and inside is 757 6. So that pressure difference will push the air from outside to inside the interpleural cavity. Make sense? So what will happen? The lungs will collapse. Okay. So usually we say the lung collapses if the accidental perforation occurs here in the pleura. So the
even if
air
it's
will
not a
get in.
puncture, if it's a good strong hit, it can happen, right?
If inside the body the rupture occurs, somehow it should let the air get
Okay,
in.
but not from outside
It
necessarily.
could be inside, but usually we see from outside. Accidental, injury to the thorax, or that can happen.
Falling into something, yeah.
Okay, or inside injury can also do that. Okay, if you press the rib hard from outside, you won't see the injury outside, but the rib can pierce through the pleura. So you understand why the intrapleural pressure must be negative, right? To keep the lung expanded. Now, you see why the intrapulmonary pressure changes. You just think it is very simple question. When the interpulmonary pressure is 759, the air from outside atmosphere will get in. Why? Because this pressure is higher than this pressure. Make sense? How much higher? Only 1 millimeter, right? But that 1 millimeter difference is strong enough to push the air inside from outside. Make sense? Okay. And when the pressure goes up to 761, what will happen? Yeah, air will go from always from high to low, right? So again, 1 millimeter pressure difference will move the air out from the lung, and that's why the interpulmonary pressure changes all the time. When it is 759, air will get in, that is the inspiration. When 761, air will get out, that is what? Expiration. Make sense? Okay, so that's the basic idea. Now the question is how the interpulmonary pressure changes. To change the interpulmonary pressure, you need to use the muscles. You see here, under the lung, you have the diaphragm. So this is the diaphragm, which is the main muscle, respiratory muscle, diaphragm. It moves up and down, attached to the base of the lung. You know, this is the base of the lung. Okay, and also you have intercostal muscles in the thoracic case, in intercostal, in between the ribs. Costal means ribs. So in between the ribs, you have intercostal muscles. Okay, so diaphragm and intercostal muscles are the muscles of respiration. Okay, now when this is very important, when you contract the intercostal muscles, when the intercostal muscles are contracted, what happens? This is important to know. The contraction of intercostal muscles will move the ribs forward and slightly upward, like this. Forward and slightly upwards. Make sense? So when the ribs move forward and upwards like this, the anterior surface of the lung will also be pulled with the thoracic case. So the anterior surface of the lung will also move in that direction because the ribs will pull the anterior surface of the muscle, lung. Make sense? So now you tell me, if your anterior surface of the lung moves that way forward, then this diameter will increase or decrease?
Increase.
Increase. You are expanding the lung this way, right? So anterior posterior diameter increases. Okay. When the diaphragm contracts, you also need to know that when the diaphragm contracts, it moves downwards. And you know that the base of the lung is strongly attached to the diaphragm, right? So when diaphragm moves down, it will pull the bottom of the lung down. So superior inferior diameter will do what? Increase this way, right? So by the contraction of your intercostal muscles and diaphragm, you expand the lungs. And when you expand the lungs, what happens? Inside the lung, the pressure, air pressure will go down. If you expand something, the pressure inside goes down, right? So that will change the pressure, reduce the pressure to 759. So the air will get in. That is the inspiration. Now you see that active process because you are contracting the diaphragm and intercostal muscles, right? Now, when these muscles will relax, that is not active process, the muscle will relax. The muscles are now soft, and you know that the lung is highly elastic. So you have expanded by force. Now if you leave that pressure, then the lung will recoil. And again, will go back to its actual shape. And that will increase the pressure to 761 and the air will get out. Okay, so the inspiration and expiration. Now, if you want to forcefully expire more air out of the lung, then what you have to do? You have to use the abdominal muscles, these muscles. You know that your abdomen has 4 muscles, right? You remember rectus abdominis, external oblique, internal oblique, transversus abdominis. The abdominal muscles are used for forceful breathing. And you know that in many instances we use the forceful breathing. One is exercise. When you do the exercise, your body requires more oxygen, right? So you need to take more oxygen and expire more carbon dioxide out. If when you vomit or sneeze or scream, okay, when you scream or fluctuation, you know, that delivery, giving birth of baby, right? We use the abdominal muscles a lot. So abdominal muscles are important for forceful breathing. So now if you just go over this, you will understand. I have explained this to you. Surfactant. Surfactant is a fluid formed by lipid and protein. So basically lipoprotein or lipoprotein. Surfactant is a lipoprotein and secreted by the type 2 cells of the alveolar wall. We have talked about that in last class. Those are called surfactant secreting cells or type 2 cells. And what happens, the surfactant after secretion, the surfactant lines the inner surface of the alveolar wall like this, okay, and reduces the surface tension. So this is the surfactant, the fluid. It lines the inner surface of the alveolar. This is the alveolus.
It
Okay.
reduces friction.
Yeah, reduces the surface tension.
Surface tension.
Yes, reduces surface tension. So the wall can stay expanded. Okay. Uh, so that helps to keep the alveoli open. Okay, keep the alveoli open. Now, if for any reason the surfactant is not secreted, it can happen due to lack of surfactant secreting cells in the wall. It can happen genetically, genetical absence of surfactant secreting type 2 cells. That can happen, or in premature birth, if the baby borns premature, then what can happen? The lack of surfactant secreting cells could be present in the alveoli of the lung, and the amount of surfactant would be less. So those are the two reasons, main reasons. One is it can happen due to genetic disorder or premature birth. In that case, anyway, the infants uh, will have lack of surfactant in the alveoli. So the alveoli will collapse, and that is called surfactant infant respiratory distress syndrome. Infant respiratory uh, distress syndrome. Okay.
Is there any way they treat that now? I mean, I know they used to say, well, if the surfactant wasn't there, then the baby cannot survive, but it seems like the babies are surviving younger and younger, so are they coming up with a treatment for that?
If if that happens due to premature birth, in those cases you can keep the baby alive if you try and if it works. But if it is genetically absent, you can't do that treatment. Okay, so the baby will die. So most of the cases, the baby will die unless premature birth and you take care of that baby. Uh, uh, and in that case, the alveolar wall uh, has the cells, but not completely formed cells. So immature cells, those you can stimulate them to produce more surfactant by medicine. You can stimulate them. But if there is no surfactant secreting cells due to genetic disorder, then you have no hope. You can't really do. You can't put the surfactant there. Those are microscopic alveoli. Remember. Okay. So that's the surfactant and its function. Okay, now we'll talk about the respiratory volumes and capacities. Partial pressure of oxygen and carbon dioxide and the movement of oxygen and carbon dioxide. Factors influence the oxygen saturation. What is that? Actually, you know that your hemoglobin binds with the oxygen, right? Hemoglobin binds with the oxygen. So how much oxygen is getting attached to the hemoglobin? That is the saturation, right? And we'll see the regulation of respiration. In your brain, you have the respiratory centers, like cardiac centers, and those respiratory centers regulate the breathing. So first, the respiratory volumes and capacities. There are 4 volumes and 4 capacities. Now, the respiratory volumes and capacities are measured to do the lung function test. So those measurements are basically lung function tests if your lungs are functioning normally. So 4 volumes are tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Now, if you add 2 or more of these volumes, you get the capacity. So basically, we get the capacity by adding 2 or more volumes. So we'll see what are the capacities: inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. Okay, so first we'll see the volumes. Tidal volume. Tidal volume is the volume of air or amount of air you inspire or expire in normal breathing. So you are breathing in quite normal resting condition. How much air you inhale or exhale. That volume is the tidal volume. It is about 500 milliliter of air. And remember, same amount we inhale and exhale. Now, inspiratory reserve volume. Just think the name. Inspiratory, right? So, during inspiration. Why it is called inspiratory reserve volume? You see, if I ask you to inhale normal amount of air, 500 milliliter, right? You inhaled. Then, if I ask you stop there and try to inhale more, can you do that? After normal amount, you have taken normal amount, and if I ask you do more, take more, can you do that? You can do that, right? And the extra amount of air, the additional volume of air you can inhale forcefully after normal inhalation. Make sense? So after normal inhalation, the additional volume you can inhale or take forcefully. That's the reserve volume. That means what? Reserve volume means the volume we can use, but normally we don't use, right? That's why it is called reserve. When you need, you can use that. When you need that.
When you dive or underwater.
Dive underwater, right? You try to take as much as you can, right? So you fill your lung with as much as air you can. Then you go underwater, right? So we use that. Also, we use the reserve volumes when we do exercise because you take more, right, than normal. So we do that. Expiratory reserve volume, just opposite. After normal expiration of air, if you try to push more air out, you can do that, right? Forcefully, you can expire more. That is the expiratory reserve volume. So amount of air you can forcefully expire after a normal expiration. Residual volume is the volume of air that remains in the lung after forceful expiration. So, see the situation. If I ask you to try to push all the air out from the lung forcefully, okay? Still, some amount of air will stay inside the lung. You will never be able to push it out. Make sense? So, if I ask you to push all the air out from the lung, still some air will remain in the lung. Is it clear? That is the residual volume. Now you tell me why you need the residual volume. You need some air to stay in the lung even if you forcefully push all the air out.
They're stuck together.
Yeah. So number one, it will keep the lung expanded. Number two, that is also important. You see, if you stop breathing, for example, you are not breathing, will your heart stop? No. If you just temporarily stop breathing for a few seconds, your heart will not stop, right? Will never stop. So heart is continuously sending blood to the lung to get the oxygen, right? Blood is going to get the oxygen. So if all the air you forcefully push out, then what will happen? The heart will still send blood to the lung, right? And blood will come back without getting any oxygen. Make sense? So suddenly the oxygen concentration in your blood will change, will drop, right? That is not good. Is it clear? So to ensure that your blood is getting at least some oxygen. That's why you need some amount of air remain in the lung. So two functions. One is to keep the lung expanded. Number two, to ensure that the blood doesn't come back without getting any oxygen. If that happens, the amount of concentration of oxygen will suddenly drop in the blood, right? That will cause acidosis. Increased carbon dioxide cause acidosis. Okay, so just from this one, you need to know the definition of those four volumes that I have explained, and at least two volumes, the amount you have to remember. One is the tidal volume and another is the residual volume. Okay, residual volume is 1200 milliliter in male, adult male, and 1100 milliliter in adult female. Now the capacities, four capacities. So how you get those capacities? Total lung capacity you get by adding all those four volumes. If you add all four volumes together, that will give you the total lung capacity. You need to remember the amount. In adult male, total lung capacity is 6 liter. In female, 4.2 liter. In adult male, it is 6 liter. That means 6000 milliliter, right? 6 liters. And in female, 4.2 liter or 4200 milliliter. Tell me why in male, adult male, the total lung capacity is more. That's very simple, right?
The bigger and more muscles.
Yeah, muscles are stronger, respiratory muscles are also strong, right? And the size of the lung is big. Vital capacity. If you add three volumes, tidal volume, inspiratory reserve volume, expiratory reserve volume, you get the vital capacity. Inspiratory capacity. If you add the tidal volume and inspiratory reserve volume, that will give you the inspiratory capacity. Okay. Then the functional residual capacity. Remember, you got the residual volume before. That's the amount of air remains in the lung after forceful expiration, right? After forceful. That's the residual volume. But this one, functional residual capacity, is the amount of air remains in the lung after normal expiration. After normal expiration, how much air remains in the lung. So two different things. This is a nice chart showing the change of volume of air inside the lung. Remember, inside the lung, you are looking the change of volume inside the lung. So first, you see the middle part, that's the normal respiration, normal inspiration and expiration. So you tell me, this is the total lung capacity, and here is it. Okay, so you are looking the amount of air inside the lung or volume of air inside the lung, and this is tidal volume. That means normal respiration. Normal respiration. So the volume inside the lung will increase. The volume of air inside the lung will increase during inspiration or expiration. Inspiration, right? So it is going up. That means that is inspiration. Okay, and this is what? Going down. The volume is going down. Expiration. Make sense? And then inspiration, expiration, and that amount is 500 milliliter. Okay, 500 milliliter. Now, if you take normal amount of air, normal inspiration, now I ask you stop there and take more forcefully. You can do that, right? That means inside the lung, you are taking more air forcefully. So the volume inside the lung will increase, right? That is the inspiratory reserve volume. Inspiratory reserve volume. Okay. Now coming back to normal, and after normal expiration, if I ask you to do forcefully, expire the air out, so inside the lung the air will go down a lot, and that amount is the expiratory reserve volume. Make sense? Expiratory reserve volume, this amount that you can forcefully exhale out. Now, even after you forcefully expire the air out, what will happen inside the lung? Some air will remain, right? You remember? Some air will remain. That's the amount will remain in the lung. And that is what? Residual. Okay? All those two important functions. Okay? So now if you add two or more of these, you will get the capacities. Okay? So that's how you can read this chart, and this is a nice chart. I like this. Okay, dead space. The air that does not participate in gas exchange. Okay, that is the dead space. For example, your respiratory tract has two zones. You know that, conducting and what? Conducting zone and respiratory. Just the day before yesterday, we have talked about that respiratory zone. So gas exchange occurs where? In which one? Which one just transport the gas, and where the gas exchange occurs? This one only to do what? That's the upper part of respiratory system, right? Only to passes the gas. And exchange occurs here, right? Make sense? So the air inside your nose or inside the conducting zone, inside the larynx, pharynx, trachea, do they participate in exchange? No. So that is the dead space, because I said that dead space where the gas does not participate in exchange. Make sense? So the air inside your conducting zone is dead space. What dead space? This is anatomical dead space. Why this is called anatomical dead space? You know that our respiratory system is built like that, right? All of our respiratory system is built like that, that your nose will only take the air, right? Your trachea will only take the air inside. No exchange will occur, right? So that's the anatomy, normal structure of your body. Make sense? Those structures are made like that, designed like that. Now, that's the anatomical dead space. Now you see, you have, that respiratory bronchial, alveolar ducts, and alveoli. Those three belong to what? Which zone? Respiratory zone, right? Respiratory bronchial, alveolar duct, and alveoli. Now, you just think that all these alveoli are designed to do what? Gas exchange, right? Gas exchange. Now, you smoke too much. Someone smokes, okay? And the carbon particles have blocked this very narrow alveolar duct here. So no air will get in here, right? No air will get in to those alveoli. So this is what now? Dead space. Make sense? Because these alveoli are not participating in gas exchange. But actually they are designed to do that, right? Do the gas exchange. But because of the clinical condition, abnormal condition, they are not participating. Yeah, that's the alveolar space. Okay, so if any alveoli don't participate in gas exchange, that is the alveolar dead space. Okay.
So what about if they're overexpanded where they're worn out, they no longer want to expand, that's still dead space? Though they're not physically blocked.
Overexpansion of what?
Yeah, like asthma or something.
Yeah, in asthma, all the alveoli actually gets air, but due to constriction, usually not complete constriction occurs, like constriction of the bronchioles occur, okay? And that will reduce the amount of gas going to the alveoli. But if any constriction that can completely close that, definitely that's the alveolar dead space. And alveolar dead space is not fixed. Make sense? Because this is alveolar dead space. Now if I can remove this, then what will happen? Again this alveoli will function, right? So this is not fixed. But the volume inside the nose, is it fixed or no? It is fixed, right? Because inside the nose or trachea, the volume is kind of fixed because those are the anatomical structures. So the alveolar dead space is not fixed, it can change. But the anatomical dead space is fixed, the volume is fixed. So that is due to the problem in respiratory system, the blockage of the respiratory duct or tract. Now you see, another thing can happen. If someone has heart failure, you know that lung has three lobes. The lung has 2 or 3 lobes. So this is the lung, okay, and you have alveoli everywhere in the lung, millions. Now, what happens in heart failure? The blood flow goes down significantly, right? Because heart cannot pump the blood, very weakly pump the blood. So in that case, what can happen? The blood can accumulate here, but cannot reach to the alveoli, to the top of the lung. Okay. In that case, these alveoli are functioning, but blood is not going there to get the oxygen, right? So exchange of gas will not occur in this part. So that also can cause the alveolar dead space. Or this is the pulmonary branches of pulmonary blood vessels. Now see here, if any blockage occurs here, another example, then these alveoli are normal functioning, but blood is not reaching to this area. Make sense? So blood is not reaching there because of the blockage of the artery. So what will happen? Exchange will not occur. Make sense? Gas exchange between the blood and the alveoli will not occur. So this part is non-functioning. Is it clear? This part is non-functioning. So the alveolar dead space can be created due to the blockage of the respiratory tract or decreased or stoppage of blood flow. That is the problem in the cardiovascular system. Okay. So now if you can treat the person, again the alveoli will start to participate in gas exchange and it will change. Total dead space. If you add the anatomical dead space and the alveolar dead space together, that gives you the total dead space. Just know that anatomical dead space in adult person is about 150 milliliter. Okay, let's stop here. At least